everyone. Welcome back to season 2 of Let's Talk About It with Kelly. This is my husband, John. He's the trichologist at Freedom Clinic, Toronto. And I'm Kelly. The topic today is challenging hair loss cases in your clinic. This is going to be a good one.
Okay.
What's one hair loss case that kept you awake at night because it was so difficult to diagnose or treat?
The most challenging case I had is fairly recent.
Really?
So it's a woman came in and she had significant hair loss through the frontal area about halfway back and all down one side.
Just one side?
There was a couple of patches here and there. Mm-hmm. The back was normal. I'll say that with a Corelli. It wasn't normal after I examined it. It looked normal. So she had been to a couple of, probably 3 different practitioners, a dermatologist, mm-hmm. who diagnosed it as frontal fibrosing alopecia, which it kind of looked like, but did a biopsy. Mm-hmm. And the biopsy came back as androgenetic alopecia, which, when you look at this, it makes no sense at all. There's a big bald patch here, and it's smooth like alopecia areata, smooth. There's some areas that have a little bit of stubble. Okay. I'm looking and then I start to see some areas of like damage, like there's scabs and there's some wounds, a little bit of scarring. So she has had steroid injections in one clinic. She had that one diagnoser or the diagnosis of the frontal fibrosing. And then she comes to me, and I sort of figured once I started talking to her, looking at her history, mm-hmm. and what I saw on her scalp, I kind of knew that this had to be something psychological, that this was a type of advanced trichotillomania is probably the wrong word, but it was a person who was going through a lot emotionally and was removing the hair on her scalp. Logically, she felt there was something under her scalp and she was trying to get it off, and she would dermaplane her scalp. So that's why it was completely clean. She was like a razor. She was dermaplaning it. The hairs, a lot of them went into dormancy completely. So when we looked at it under the microscope, we didn't even see the stubble in a lot of areas. It looked scarred. Mm-hmm. It looked scarred under the microscope because there was nothing unusual there. It just looked like it was done. But there were other areas where I could see the broken hairs. The areas of wounds were areas where she just kept scraping and scraping. So it was very wounded. I say trichotillomania. It's not trichotillomania. It's much more serious than that. This was in a lot of ways, a self-mutilation. The family history seemed pretty normally. Like she didn't seem to be having any problems. Mm-hmm. Mm-hmm. But maybe there's something there. Mm-hmm. But this is one of those cases where the person is in denial about it. Now she told me she was dermaplaning the hair off. Because she said, but something keeps going back. There's something in my scalp. So when somebody thinks there's something in their scalp and they pull their hair, or they keep shaving it, or they're scratching and causing wounds because they're trying to dig something out of your scalp, mm-hmm. we call that delusional infestation. So where you think you're infested, maybe with bugs or mites, okay? Yeah. Or even demidex or some kind of little tiny bug in your scalp, and you're mm-hmm. determined to get it out, and you end up, the person ends up scratching, scraping,
Could that sensation be real, though?
It could be real. There's cases of something called scalp dysesthesia, which is where your nerves are sort of playing havoc, mm-hmm. wreaking havoc on your scalp. Mm-hmm. When you look at it, you usually don't see anything abnormal. So the person will come in and they'll have this abnormal feeling in their scalp. Of course, they'll get dismissed everywhere else. But they have this feeling in their scalp, and it's causing these things, and they come in trying to figure out what's wrong. That could lead to a response like this, but usually it's a response to something else. There's some other reason why. I don't really know why. That's something for a therapist, a psychologist, or a psychiatrist.
So this lady kept you up at night?
So I talked to her so much and tried to get her to understand that what she was doing was a known sort of obsessive behavior.
Tried to put a name on it. That kept you up.
I tried to put a name on it. Okay. She kind of accepted it initially. And then I got a letter after the initial. So I did a consultation. We come up with some ideas and and we were supposed to follow up. I got a letter a few days later, and she had sort of denied everything that I had told her and diagnosed her with. And this really bothered me because I can't help her now. There's nothing I can do. And that's, when you know something so firmly and surely, and you know they're not going to get it helped properly, that keeps me up at night. That really bothers me.
So you diagnosed her with a couple things, and then she didn't want to believe that.
That's right.
And that was kind of a pattern with other physicians as well, right?
So a lot of physicians will see this and they don't know how to approach it. I mean, a lot of people, it's a difficult thing to try and approach. So they'll try and diagnose it. Like this one doctor said, okay, it's fibrosing alopecia. We'll try treating it. We'll give it steroid injections, but we'll take a biopsy to make sure. And biopsy comes back androgenetic alopecia. Incidentally, I wanted to mention the reason it showed androgenetic alopecia was because of the constant pulling. So she did do a lot of pulling, there were areas of pulling. So she damaged some follicles. So some follicles were producing miniaturized hairs because they're damaged.
Yeah.
Traction alopecia can do this. It can mimic alopecia, androgenetic alopecia. So under the biopsy, it looks very similar. Okay, in a lot of ways. So this is why, because she did not have the areas that were growing normally in her scalp had no androgenetic alopecia. There was no miniaturization. The one thing that was happening, another thing that was happening that was really bizarre that I wasn't able to get to the bottom of, is she had extreme anagen effluvium in the back of the scalp. What's anagen effluvium? Anagen effluvium is what happens when cancer patients are taking chemotherapy, causes hair to fall out. So the hair comes out in the anagen phase. It doesn't go to rest. The follicles don't go to rest. The hair just falls out and it's still growing.
Right.
So when I did my pull test on the back of her scalp, I got a handful of hair. And when I put it under the microscope to check the bulbs, anagen bulbs, no telogen bulbs.
So it's still alive.
It doesn't make any sense.
So it seems like she had quite a few different ones. Well,
there was something going on back there. I don't know if that was from a medication or something she was on or something she wasn't telling me, but it was bizarre, and it's something I'm going to take up as a very specific case because this is
with Dr. Donovan.
Yeah, I'm going to bring that up in the alumni because it's really something unusual, extremely unusual. I have seen anagen effluvium before, but not like this. This was bizarre. But anyway, because I couldn't treat her, I couldn't get her, and she kind of shut me out. That really bothered me.
So we have no idea what's happening with her today?
No.
Oh.
No.
That's going to keep me up now.
Exactly.
Jeez.
Yeah.
How often do underlying medical conditions turn out to be real cause of hair loss?
It's not that common, but it does happen. So one of the more common causes of like a medical condition causing hair loss would be lupus.
Yeah, it's one we don't talk about much.
Yeah, so lupus, there's different types. There's lupus that affects, your internal organs, and, it attacks, and it's autoimmune, and it attacks the organs. But there's a type of lupus that really starts in the scalp and doesn't always progress, throughout the body. And this often expresses itself as a scarring alopecia somewhere in the top of the scalp. So we see this, a person comes in or they go into a doctor's office or a dermatologist and they have a little patch of hair loss and they see it. With the naked eye, it might look like alopecia areata. It might look like, usually it looks, might look like alopecia areata or maybe lichen planopilaris or something. But when you biopsy it, then we Well, when we look at it under the microscope, we can differentiate it from other types of scarring alopecia. So the underlying cause there would be lupus. Most scarring alopecias don't have underlying causes. They exist on their own. They're just some kind of autoimmune disorder. There are some, comorbidities. Sometimes we get psoriasis, or a person will have arthritis and get other types of autoimmune, or diabetes is sometimes associated with CCCA sort of thing. So certain autoimmune conditions, the person might have an underlying autoimmune syndrome. But there's not a lot of diseases that, thyroid disease, of course, can cause hair loss. So, but these aren't that common. They do happen, but they're not that common.
Compared to the volume of patients that you have.
That's right, yeah.
Okay, I see. Okay, how do you support patients when treatment results are slower than they've hoped for?
Wow, that's a tough question. So we try new treatments. We'll add on treatments. Of course, we keep motivating them and encouraging them, and we just do everything we can to help the person, and support them. And usually, if a person comes in and we're working with them over a long period of time, that itself really comforts them. But if we get to the point where, the hair loss is very difficult to improve, again, you just have to, you have to support them. You have to try and come up with new ideas, ways to help them. There's always another option, right? So. Right. We have to be flexible in our options. I have to be able to say, okay, well, maybe you should see this specialist, or maybe we should try this, or have you thought about this?
Or are you staying consistent? Are you doing it 4 times a week? Are you taking putting the Trichologist on every single day?
Yeah, so
that kind of thing, and follow-ups.
Keeping them motivated through follow-ups, supporting them in the long term. Noting improvements really helps, because it really
photos are incredible.
Yeah, we got to really monitor the progress and show it to the patient so they can see when they are progressing.
Okay, perfect. Thanks, John. What's the toughest hair loss condition to treat successfully, and why? I think you kind of scarring alopecia, I would say, right?
No, not really. They're all tough. They're all tough.
They're all
to treat.
tough. Okay,
because some of them are, scarring's tough to treat because you can't regrow the hair, right? Androgenetic alopecia is very hard to treat because any treatment you use has to be continued forever.
Pretty much,
right?
I would say.
Yeah, well, if you stop the treatment in androgenetic alopecia, the androgenetic alopecia returns. We get really good responses now with our treatments that we're using at Freedom Clinic. Now we're getting some amazing responses in androgenetic alopecia, so that's a really good thing.
With the Trichologist?
Trichologist, and often in more advanced cases, we'll combine the Trichologist, with those other therapies that I like, laser therapy, PRP, and then, of course, going through their whole history and making sure everything is good with their health and their scalp health and their hormones and all that stuff. So, really getting this complete treatment picture really helps a lot of people significantly now. But it's difficult because I'm not going to say there's non-responders. Some people say, finasteride has non-responders. I often think it's, there's other factors involved. They're not being monitored properly. They're not seeing it clearly. They're not, maybe they're not taking the medication properly or whatever. So
or they're not being educated on actually what's happening.
Yeah, or how to use it, or how to use it properly. So, and being followed up and monitored. So, a lot of people will start a treatment and 3 months later say, "Oh, this isn't working," but that's too soon. It's too soon. Yeah. You got to give it time. The treatments we have for androgenetic alopecia can be very successful if they're done properly, but the challenge is, keeping the person motivated. Showing them the results and keeping the treatment ongoing. So that's what's difficult about androgenetic alopecia. Scarring alopecia, we talked about. Alopecia areata is usually pretty easy in the early stages. Really all you're going to do is work with some steroids at first, and most of the time takes care of the issue. unless it's a super extensive type of total alopecia or alopecia universalis, where you get total body hair loss, and it's much more complicated. You start to have to bring in these drugs and things like that. But they're all challenging on some level.
Right.
And you can't say one's more challenging than the other. They're just different types of challenges.
Right. Thanks, John. Just one more question, if you don't mind. After treating thousands of patients, what's the biggest lesson these challenging cases have taught you about hair loss?
Well, the biggest lesson is, listening and then monitoring. It's so important that people keep coming back, because they'll come in once, we do a diagnosis, say we started even a treatment. Then they go out and they've learned a lot, but they'll start doing some research, which is fine. But often what happens is they're going to run into a bunch of misinformation. That might color what they've been taught with us. So it's so important that the people are coming back, re-challenging me. If I've told them something and they've heard something else, so they come back and say, John, I read this, I saw this, da-da-da-da-da. It's so important that they can come back and discuss that, so that we can answer questions, make sure people have all the right information to make the decisions they need to make. They want to, everybody wants to do more and more for their hair loss. They want to find that magic cure, right? And there's so many people and so many organizations out there preying on this vulnerability with people and selling them snake oils that do nothing. Right?
Yeah, and it's almost better to put the cart before the horse, where you mention these.
Yeah, I see what you're saying. Yeah,
in your
we do that sometimes. We do that initially.
Don't listen to the crap that's out on the internet.
Yeah, that's always part of the consultation is beware of all the the scams
injecting
out there.
Peptides and crap like that.
Injecting peptides. Wow, that's a scary one. But yeah, the thing is so the most important thing that I've learned, and for me, is to try and keep people coming back. And it's not a big deal. Like, you come in once, and then we do a month follow-up usually of when person starts something, and then we see them every 3 or 6 months, depending on the situation. And as long as we're doing that, we can really keep the progress going. But if the person stops coming, then they could be falling off their treatment. They could be trying things that aren't working. They could have some other frustration or what have you. If they're doing something, with someone else, I want to know about it. So I know what they're doing. I can say, okay, now they've moved out of town, or they decided to do, this treatment over here. That's fine. I like to know about it. But, it's really important that we teach people that hair loss is an ongoing thing that needs to be monitored on an ongoing basis. Okay. So that's really important.
Thank you, John. I'll tell you what I've learned. I've learned that you can't treat everybody and get the same results.
Absolutely.
I think that's what I've learned. There's not
one size fits all, and various treatments for different types of hair loss. And the other thing is, we have this thing, and this is probably something that many practitioners have in their head, is that 95% of all hair loss is androgenetic hair loss. That's not so true anymore. I bet if we did new studies adding up what types of hair loss, the numbers are going to be a little bit more skewed. The thing is that even if it is 95%, that means 1 out of 10 people is going to be something else other than androgenetic. But every one that comes in for the next 100 people, you're going to think is androgenetic, probably, most likely. So when, a person gets a little bit of thinning hair in the crown, that could be a number of things. It could be a few different types of scarring alopecia. And it could be a fungal infection. It could be all kinds of things, right? It could be really bad psoriasis. People come in, go into clinics, and a dermatologist sees them, my scalp's itchy, and they give them some steroid cream. Oh, it's just itchy scalp. It was steroid cream. Well, they come into me and I look under the microscope and there's a little tiny patch of scarring alopecia in there that you can't even see.
Wow.
You know, go get a biopsy. It comes back lichen planopilaris. Let's start the steroid injections.
Yeah, you see that all the time.
All the time.
All the time.
So
Wow.
it's more, so I would say more about, you know, probably in my practice, probably 70% of the people are androgenetic hair loss, men and women.
Mm-hmm.
But there's often more complicating factors involved. And we're often dealing with other types of hair loss.
Wow. Very interesting. Thank you, John.
Okay, yeah, that was good.
That was a good one. Thanks, guys. We'll talk to you later.
Stay tuned for the next episode.
It's going to be a good one.